Welcome to CANVax's webinar series. Since fall 2019, we have been hosting webinars exploring current and emerging immunization topics to support and inform the work of public health professionals to improve vaccine acceptance and uptake. To learn more, please visit our website at canvax.ca/CANVax webinar series, as indicated in the link you see on the screen. Before we begin, we want to acknowledge that the Canadian Public Health Association's office is situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. We would also like to express our deepest gratitude to all the frontline essential workers dealing with the COVID-19 pandemic. Thank you all for your hard work in keeping us safe. Today's webinar, Midwives and Vaccinations, Delivering Informed Choice Discussions, is brought to you by the Canadian Public Health Association through the CANVax project and its partners Immunize Canada, the IWK Health Centre, and the Institut National de Santé Publique de Québec. I'm Antonella Pucci, CANVax Project Officer with CPHA, and I'll be the moderator for this webinar. Also assisting me is my colleague Rutian Zhu, who is also a Project Officer for CANVax. As for a bit of housekeeping, it should be noted that all Zoom attendees are muted. If you have any questions for the presenters, please type them in the Q&A box at any point during this webinar. All questions will be answered in sequence at the end of the presentation. Only you, myself, and the presenters can see your questions in the My Questions section. There's the option to also submit anonymously if you like. When asking a question to the presenters, the question is first read out loud, answered live by the presenter, and then posted in the All Questions section. If you have any questions regarding technical difficulties, please also ask them in the Q&A box and we will also address them. We strongly encourage attendee participation and we look forward to hearing your thoughts and questions. As for just a few quick notes, our webinar is being recorded and will be made available on canvax.ca and CPHA's YouTube channel a few days after this presentation. Presentation slides will also be available. We would also love to get your feedback, so please fill out our 5-minute survey at the end of the webinar upon closing the webinar window. And finally, if you haven't registered with CANVax or subscribed to our newsletter, visit canvax.ca today to do so. So with that, I'd like to introduce our speakers for today's webinar. Our first speaker is Jasmine Chatelain, who is a registered midwife who has primarily practiced in the Ottawa area. She has also participated in several participatory action research and clinical knowledge translation projects. Most recently, Jasmine worked on a joint Canadian Association of Midwives and National Aboriginal Council of Midwives project funded by the Public Health Agency of Canada to assess current midwifery scope and practice around immunization and midwifery client needs for informational materials regarding immunization. She is currently the director of the Midwifery Education Program at the Cree Board of Health and Social Services of James Bay in Quebec, working with CAM and NACM and the University of British Columbia's Continuing Professional Development team to develop an online educational module around immunization geared towards midwives. Our second speaker is Fallon Cooper, who is also a registered midwife working in the lower mainland of BC for the past 8 years. She has a particular interest in the role that midwives play in vaccinating midwifery users and their families. Fallon is the Midwives Association of BC representative on the Professional Engagement Working Group for the BC CDC's Immunization Committee, and she has acted as a midwifery consultant on various vaccination projects through the Vaccination Evaluation Centre. She recently sat on the Midwifery Advisory Committee for the Public Health Agency of Canada and the Canadian Association of Midwives joint project to develop a position statement and midwife and midwifery client-focused resources. So with that, I would like to introduce both of our speakers. Jasmine, whenever you're ready, you can start sharing your slides.
Thanks, Antonella. My name is Jasmine, and I'll be doing the first part of this presentation today, and then I'll be turning it over to Fallon. I have to admit, I find presenting on Zoom a bit cumbersome, so I'll ask you to bear with me. So as Antonella said, I'm going to briefly describe a project that the Canadian Association of Midwives and the National Aboriginal Council of Midwives did together in 2019-2020. I'm going to briefly look at the opportunities and challenges posed for midwives when discussing immunization with clients and how other healthcare providers might benefit from our perspective and materials. So in 2018, PHAC did a survey of various healthcare providers' views and experiences around vaccine hesitancy, including midwives. And what that research showed us was that midwifery clients tend to be more vaccine hesitant, and we see lower levels of vaccine uptake with our clients. So in response to that, PHAC funded, I'm going to say CAM from now on for the Canadian Association of Midwives, and NACM for the National Aboriginal Council of Midwives, funded for us to do a project around that. And I'm going to briefly describe that project. Before I do, for those of you who may not be familiar with how midwives work, I just want to, a quick note, let you know that registered midwives and Indigenous midwives are primary caregivers for the perinatal period, usually up to about 6 to 8 weeks postpartum. We attend births at home, in birth centers, and in hospital. And our model of care is based on several guiding principles, but key ones are continuity of care, informed choice, choice of birthplace, and the protection of normal. I think that it's important for me to take a minute to delineate what we mean by informed choice, because this entire presentation is built in the context. So I'm just going to quote this. This is from the CAM position statement called the Canadian Model of Midwifery Care, written in 2015, which you can see on our website. Midwives recognize the right of each person to be the primary decision maker about their care. Informed choice requires cooperative dialogue and encourages shared responsibility between client and midwife. Midwives share their knowledge and experience, provide information about community standards, and offer evidence-based recommendations. Midwives encourage clients to actively seek information, ask questions throughout the process of decision-making. We recognize and respect that clients will sometimes make choices for themselves and their families that differ from our recommendation and/or community standards. In such circumstances, midwives will continue to provide access to the best possible care. Okay, so our project had these three basic objectives and activities. First of all, we wanted to gather some information around what's already happening for midwives and immunization. We wanted to gather information around some of the attitudes and perceptions and challenges midwives face. And then we also wanted to find out what midwives felt would be useful informational materials around immunization. We also canvassed midwifery clients around these three things. The second activity was we wanted to take that information that we gathered and use it along with some research to inform the creation of a position statement. And finally, we wanted to take that information and create some informational materials. So I just want to make a quick note that although our survey was ethics approved, our focus groups and our key informant interviews were not, as it was decided that this was really just sort of a somewhat informal needs assessment, community consultation, and not scientific research per se. I'm going to really quickly go through this, but basically we had a Canada-wide survey with an overwhelming response from midwifery clients. Over 2,400 clients responded. And 320 midwives responded. We had questions specific to Indigenous people as well, and we cross-tabulated all the responses by Indigenous population and by province. We did focus groups in British Columbia, Manitoba, Ontario, and Quebec, in person and virtual. We had some groups exclusive for Indigenous midwives and clients. We had low numbers of participation, mostly because we were right in the middle of focus groups when COVID-19 arrived, and we just decided that it was impossible. It was unrealistic and unethical at that point to ask midwives and clients to do more. So we don't have the numbers that we would have wanted. After that, two midwife researchers used a deductive thematic analysis and came up with some central themes. Our key informant interviews were basically 10 people working in institutional roles and included pediatricians, midwives, public health researchers, and midwifery educators, Indigenous communication specialists, and vaccine critical spokespeople. So the key messages we heard from midwives was, first of all, and this is important to remember throughout the rest of the presentation, is the majority of midwife respondents supported vaccination. And given Indigenous communities' health indicators, risk factors, and inequitable lack of access to public health measures, Indigenous midwives felt that need even more intensely. Midwives, their knowledge, competencies, scope of practice, and practice management vary widely across the country, and even down to the practice level or individual level. Almost all midwives uniformly said that they needed some more education. Interestingly, Indigenous midwives felt more confident, and we believe that they tend to, that reflects their client populations and the work that they're doing. Midwives said that informed choice discussions around immunization are important. Half of non-Indigenous and a quarter of Indigenous midwives strongly agree that providing clients with comprehensive information on the recommended vaccinations of pregnancy is a necessary part of client decision-making. Indigenous midwives felt that their informed choice discussions may be less complex for Indigenous clients because their communities are more vulnerable to infectious diseases, and therefore they have less choice around what they feel they can do. Also, a very important message was that Indigenous people's troubled history with infectious diseases, immunization, and the Canadian Public Health agencies is an essential component of an informed choice discussion. Providing informed choice discussions on immunization is important. However, midwives find it very challenging. Only 5 to 25% of midwives feel confident about their informed choice discussions. Reasons cited were gaps in knowledge and lack of training, lack of access to primary data, lack of comprehensive midwifery vetted evidence-based information, fear of client reaction or undermining the midwife-client relationship. Current public health messaging is problematic. A general social climate where questions and concerns around vaccines are not considered acceptable. Fear of ostracization from other midwives and healthcare providers, general discomfort with the topic, and feeling it is not appropriate to the midwife's role. I have a quick example here of a public health website, just to, this is really not meant to be critical or judgmental around public health, but it's really just a way of hopefully providing a little bit of insight as to how midwives and clients might perceive something like this that they see. This is a public health website that I took from January 2020. And it also shows us the level of detail that they feel they need in order to make a decision. And very interestingly, midwives actually specifically often said that they believe providing more information would increase client vaccine uptake. So if you just look at this very briefly, pretend that you're a client, you're a midwife reading this. If you are pregnant, you can safely get the flu shot. If you're breastfeeding, you can safely get the flu shot. So what does safely mean? How do you know it is safe? How effective is the vaccine? During pregnancy, the flu shot protects you and your baby. Plus your baby stays protected for 7 months, which is when there's a high risk for flu complications. Is the protection at the same level over the months? How many months? What does high risk mean for a baby to have, sorry, I'm just gonna move my Zoom thing over here. What does high risk mean? How much more likely is it for a baby to have flu complications than an adult? What is the risk level for vaccinated versus unvaccinated? What kind of complications? What kind of percentages? When you're pregnant, changes in your immune system can make you more likely to get ill. You have greater risk of complications such as pneumonia, but being hospitalized or even dying, premature labor and delivery, fever, which can lead to birth defects. So how much more likely is it for a pregnant person to get ill than a non-pregnant person? Can we please have some numbers? Does pneumonia seriously affect the baby? What are the stats? How likely is it that a pregnant person will die of complications from the flu? How much more likely is it if they're not vaccinated, if the person isn't pregnant? What kind of birth defects, incidents? So I'm really just using this to give you a sense of what goes through some people's minds. Sorry, I'm just, Okay. Yeah. So then I'm sorry, but there's something funny with the order of my presentation. So I'm just going to skip ahead here. The key messages that we heard from the clients were that immunization services with midwives vary from comprehensive to non-existent. So 72% of Indigenous and 80% of non-Indigenous, 80% of Indigenous respondents did get some information from their other health care providers as opposed to their midwives. Only half of clients discussed immunization with their midwife. There was minimal documentation, no information around what to look for around an adverse event, no discharge planning, and less than 10% of clients were directly vaccinated by a midwife. I'd like to note that that would not necessarily be because midwives are not willing to vaccinate clients, but that it is not within their scope of practice, depending on which province they're practicing in. Also, we heard that midwives provide better informed choice discussions around immunization than healthcare providers, in their opinion. This is because they trust their midwives. Midwives respect their decisions. They don't feel pressured. They feel like they have adequate time to ask questions. Other providers don't allow for questions or concerns. Unfortunately, we heard a lot of the fear of losing care or experiences of losing care if clients express concerns to their family physicians in particular. And generally that midwives offer generally high quality of discussion. So 50% strongly agreed immunization discussions with their midwife were effective, and 70% felt like their perspective was respected. An overwhelming yes to more immunization discussion and vaccination with midwives. I'd say 100% of clients want to talk about it and would prefer to be vaccinated by their midwife during pregnancy than by their doctor. Clients also prefer to have their infants vaccinated by their midwives, but this is not currently a choice in most places because of scopes of practice and courses of care. And reasons for that, again, they trust their midwives, they feel respected, they get the information, also convenience. And around infant vaccines, they're discharged from midwives around 6 weeks. So that first vaccine is coming 2 weeks later, and they want to go to that appointment feeling prepared. One of the things that we heard from clients around informational materials was they really wanted a midwife produced handout. They wanted it detailed with equal focus on vaccines and infectious diseases. They wanted it to be balanced, neutral, unbiased, respectful. They were hoping for resources, decision-making tools, ways of understanding research and the internet, information on the internet, some practical resources, and also to know what the vaccine critical people are saying. They wanted it to be online, downloadable, and printable. Indigenous clients were less concerned about having detailed information, more concerned about having practical information, and really are asking for an acknowledgement of Black, Indigenous, and people of color histories around infectious diseases, immunization, and the Canadian Public Health agencies in those materials. They would prefer to be able to access them in their own language, and they noted that sometimes in remote areas, internet-based information is difficult to access. However, many Indigenous people are used to using social media and YouTube and those kinds of things for information gathering. I'm gonna go back up because I apologize, my slides are in a funny order. So to go back to the informational materials from midwives, basically midwives said, we want education. We need to learn more about this stuff. We need to learn around care management. And we particularly want to be able to discuss immunization within an informed choice framework. They're looking for informational resources, including vaccine critical. And I need to say, we really debated whether midwives would want to make vaccine critical sources of information accessible to their clients, given their inability to constantly vet them. But midwives agreed that in the name of informed choice, open social discourse, and the fact that these sources of information are already public, it would be at least be legitimate to be aware of different ones should a client ask. They really want a clinical practice guideline with detailed primary data that's been midwifery vetted. Although this was a frequent request, I'm noting that it was beyond the capacity of our project. Midwives said the same thing as clients around what kind of materials they wanted. They want a midwifery produced handout that includes public health recommendations, but that is neutral and balanced in a respectful tone that assumes choice and puts equal emphasis on the risk and benefit of infectious diseases and vaccines. Both midwives and clients said over and over again, we hear all about the risks of the diseases, we never hear about the risks of the vaccines. So it feels like it's biased. They also wanted to be able to offer their clients tools for decision making, and they wanted to be able to make the handout simple to access, online, downloadable, and printable. Indigenous midwives, also like the clients, really want the BIPOC history included in it. And they reminded us that teaching through storytelling and lived experience is something that really resonates with Indigenous audiences. So taking all of that, one of the things that we did was create a position statement. Fallon was involved in that. I'm not going to go through the whole position statement, but very quickly, we had an advisory committee made up of midwives across the country who have some kind of specialized knowledge around immunization, including an Indigenous midwife. The position statement was then submitted to the CARM and NACM boards and all midwives in the country who are members of those organizations for feedback. And I encourage you to go to our CAM website and read it. I think it might be very useful for everyone, including other types of healthcare providers, to think differently about how they deliver immunization discussions. I believe it is the only statement from a health profession that actually strives to find balance between the importance of public health and the importance of informed choice and trauma-informed care. I'm going to skip through this, but I really do encourage you to go look at it. Our rationale was basically equitable access to vaccines is a human right. Reducing ill health from infectious diseases reduces health inequities in general. Providing immunization information and administering vaccines is appropriate to the midwives' role, and that midwives are well positioned to discuss immunization. Like we said, clients really trust their midwives, and that gives midwives a lot of leverage to talk about vaccines, including infant vaccines, even if that takes place after discharge. Our basic recommendations were that midwives need education and training, including the BIPOC perspective, that scope and practice and participation in larger national programs around vaccination need to be widened and cemented, that midwives need to and can improve their care management skills and practice best practice better, as well as be included in immunization research. And that information transparency from government and scientific organizations around immunization is important. So skipping ahead, I'm just going to show you, looking at my timer here, I'm just going to show you an example of our materials. So you'll see here, this is our general poster. Our slogan is vaccines, we can talk about it. We really wanted to make space for discussion, for people to feel like they could talk about it, ask questions and concerns. And we also really wanted to prompt midwives to regularly bring up the topic if clients didn't. I should just mention that all of these materials have been made available in print and online to all of our midwives and practice clinics, as well as other relevant healthcare providers and organizations. We made two what we call general decision-making posters. This wasn't meant to delve too deeply into the information around vaccines, but again, really to just prompt people that they can ask questions and that they may want to take certain things into consideration. Evidence-based decision-making, as we know, usually involves sort of overlapping information between the best available research evidence, contextual evidence, and then personal or experiential evidence. So you'll see here, we say the science, my context, me and my family. So just trying to visually contextualize decision-making for people. And we put up the parents' top 5 questions, which we got from our needs assessment, which were around infant vaccines, vaccine ingredients, vaccine safety and unknowns, rights, and rights. And of course, again, the BIPOC histories. We took that and also made a handout to give to parents, which just gets into more detail around what kinds of questions to ask and what to take into consideration. So, for example, the science, you can ask, how are the studies paid for? Can I make sense of the numbers? My context, do I live in a community with really high rates of infectious disease or not? My family, has there been a history of an adverse event in my family? We made a different decision-making poster for Indigenous people that really, at the bottom, you can't see it here, but basically we just head-on address the fact that Indigenous people have a very problematic history around this topic, and that it has severely impacted their level of trust with public health in general and around vaccines in particular. We know that addressing these issues is integral to addressing vaccine hesitancy in Indigenous populations. And in their kind of companion handout, we also tried to make it different so as to resonate more and to be more useful for Indigenous clients. So again, it acknowledges the history, it reinforces wellness and resilience and strength in Indigenous communities, and it connects vaccine decision-making to this sort of a pan-Indigenous value around community and relationships. We also put another page for, again, prompts for questions that can be asked and a place to actually write the information down. We have a lot of web pages on the CAM website, which you can also access through the NACM website on a banner. I'm going to attempt to change my screen so that I can just go online. I will ask you to just be a little bit patient with me. Oh, there's my timer. Can everybody see that? Yeah? Okay, so on here, you will see that we have a project overview and research summary. We have a glossary. We have the print posters and client handouts that can be downloaded. We have our position statement. We have resources for clients, resources for midwives that are password protected. And we have what we call a vaccine homepage. And you can just really briefly see that it's very extensive. And what we started with was normal and general education. We moved into issues around choice and consent and rights. We moved then into some of the questions and often concerns around vaccine safety. And then we took the vaccines that are recommended in pregnancy, so the Tdap and the flu vaccines, and tried to provide a sort of balanced information, both in tone and in concept, around those infectious diseases and those vaccines. And then at the end, we provided some practical information. So just going back to my PowerPoint, almost done here. Sorry. Okay. So I put the URLs here for where you can see these pages, but basically if you just Google Canadian midwives or CAM and vaccines, it'll come up. A very brief note, we were very happy to receive additional funding when we came to the end of our project for what we call a phase 2. And that project just started, and it's an incredibly tight timeline, but will be finished in a couple of months. And with this phase, what we are doing is creating an online educational module for midwives that complements existing resources or existing courses and focuses on how to address vaccine hesitancy within an informed choice framework and how to respond to Black, Indigenous, and people of color's immunization needs. I'm going to, the other thing is I'm going to make sure that you guys, I think you'll probably have access to my PowerPoint, but regardless, I will make sure that you have, that Antonella passes on Emma's information. She is the project officer for phase 2, and should you have any questions, you can reach her. So now I'm going to pass it on to Fallon. And I don't know, Fallon, if you have something to share for a screen or if you're just talking. Okay, so.
I'm just talking. So like Jazz and Antonella were saying, my name's Fallon. I live in the Lower Mainland. I work here in BC, and I have done that for the past 8 years. Jazz kind of chatted a little bit about midwifery scope and how it varies pretty substantially across the provinces and territories. I've done most of my work in BC. However, I have worked in Nunavut as well as in northern Quebec, where scope varies more so with vaccination. So I'll talk a little bit more specifically about BC. We have a pharmacopoeia. We have a scope that includes the typical prenatal and postpartum vaccinations. So I'm talking about flu, Tdap, MMR, varicella, as well as newborn vaccination for Hep B for neonates that are at risk for that. It's not within our scope in British Columbia to administer childhood vaccines. It is, for example, in scope to do that in Nunavut. So there's an example of how things with vaccination change, relatively dramatically over our country or around our country. So I was brought in to chat a little bit more about immunization in COVID and like what's happening in this time, more related to like what's happening on the ground. So I have a few kind of notes that I wanted to chat about, one of which was talking just in general about the level of knowledge that our clients have about immunizations now. So during this COVID era, the general population has learned much more about vaccinations than they've ever cared to know previously, I think. For example, my dad, who is a retired gas fitter, started giving me a lecture about how messenger RNA vaccines are different than live virus vaccines. So there's a 65-year-old who has taken it upon himself to learn a little bit through the media. The number of trials that are needed to get a vaccine to market, how test subjects work, how trials can fail, how side effects are reported, the millions of dollars that the pharmacy companies need to get those drugs to trial. All of this is being reported in mainstream media now. So our consumers are much more aware of what's going on. They're seeing the sausage being made, and now they have questions about it. So as a healthcare provider, I'm finding that we really need to I've found that we are very much actively engaging in these vaccine conversations, not just about the COVID vaccine, but about previous vaccines. So talking about the childhood vaccinations in a sense of how has this been going previously? What are the vaccines that are available? Are there multiple options? Does Pfizer make one? What about AstraZeneca? Are there different options for these, and which one would you get for your child, kind of thing? People are also seeing the COVID disease, and we're seeing a vaccination make a difference in British Columbia now. We're starting to see some effects. So one of the issues I'm sure that many of you know about childhood vaccination and about vaccine hesitant parents is that these diseases feel very remote. They feel very, last generation. So having a disease like COVID around and seeing a vaccination that's making a difference, it's allowing people to see the real world consequences again. People have talked to me about, like, why do I need to get my child a rubella vaccine? I don't know anyone who's ever had rubella. I've never seen rubella. I don't even know what rubella is. So by seeing something like COVID go through our population, it's really allowing people to see the benefits of vaccines again. So in general, I would say that we're having more conversations about vaccination. We're having more intelligent conversations about vaccination, but that the people that I'm seeing have typically been more interested in vaccinating their children. I'm going to talk a little bit about barriers here. So I think I've found really two huge barriers. The first one is the relationship that Jasmine has been talking about. In midwifery care, about half of our appointments are now done by Zoom or other virtual platform. None of our appointments now are including a whole family. The first time I'm meeting a partner is typically at the birth or in the first few days after, in the postpartum period. So it's really hard to create these meaningful relationships that midwifery care is really based upon, behind a computer screen, and when I'm only getting to meet half of the child's decision makers. So that certain level of trust between midwives and our family it's harder to come by in COVID. The other big issue that would be, I'd be remiss to not talk about, is the burnout that all healthcare providers during COVID are facing. BC, we're having, it's becoming a very large issue. The number of job postings that have come across my listserv in the last 3 months is staggering. We have colleagues who are choosing to leave the profession for their own health reasons. I have a colleague who contracted COVID while caring for a low risk or a low resource teen who was living in some precarious housing situations. She was later denied WCB coverage. She was asked to move into a hotel at her own expense to isolate away from her family. Was not able to find coverage for her work and is still needing to cover her own clients. So, doing phone appointments while dealing with COVID symptoms, you paying locums to cover for us, that kind of thing. So, it's the burnout here has been a real challenge. We midwives are not eligible for any of the COVID essential worker pandemic pay that is being doled out. We here in BC specifically, we were not provided with PPE to do our jobs safely, either in clinic, in home visits, or at home births until September. We had clients sewing us scrubs. We had clients sewing us scrub caps. We had clients donating visors and gloves from our offices from their offices that were not being used. So it's, the burnout here is real. It's really big. I work in the Fraser Health Authority. This is the hardest hit health authority in BC from COVID. Fraser Health asked everyone who has medical staff privileges to assist in a vaccination plan. So we had midwives sign up for a 4-hour course. We did this course online. We learned all about vaccinations and proper handling and how to give this specific vaccine. Midwives completed shifts in these vaccination centers for about a month. The college and the province actually shut midwives down from doing this, saying that we're no longer allowed to do this, provide this service, because the Health Providers Act that Jazz very first started in her presentation talking about defines a midwife the language that it defines a midwife is that we take care of people in pregnancy, in the postpartum, and in the newborn period. So here we are as midwives injecting non-pregnant people with this COVID vaccine, and they deem that to be outside of the scope of midwives, when we all know injecting an IM injection vaccine is not a lot different if you are pregnant or not. So this is another example of a barrier that's being placed in this vaccine rollout, and how midwives are here to help, and roadblocks are being presented. I am happy to report that on February 5th, the MABC, the Midwifery Association of British Columbia, had reached an agreement with MSP, which is the Medical Service Plan, where we actually have fee codes for immunizing people. These have to be pregnant people at this point against COVID and influenza. We also have fee codes for doing screening and doing testing. And in November, our public health officer, Dr. Bonnie Henry, made a change to an amendment of however magical this happens, to allow midwives to perform the nasopharyngeal swab to the general public. So we are allowed to help in testing sites, in testing centers around the province. So let's end in a little bit more positive matter here. What can we do? How can midwives help, and how are midwives helping during the pandemic? We're catching babies. We're providing really fabulous prenatal care, intrapartum care, and postpartum care for our families. We're keeping families safe by keeping them out of hospitals when that's a reasonable option. We're keeping them safe by limiting our interaction with our clients and with their families. In fact, keeping ourselves safe. We're using our position in their families to advocate for public health measures like vaccinations, like breastfeeding, and like safe distancing and proper hand washing techniques. We can lighten the load for public health by helping screen our clients, knowing how test centers in our area work, by staying up to date on COVID-related information. We can now test and screen our clients when appropriate. One day, maybe soon, we'll be able to immunize alongside our physician and nursing colleagues. And we can talk about vaccines with our families and keep their babies safe going into the future. So I think I'm going to pass it back to Antonella. I see we have a few questions in the Q&A.
Yes.
That we can go through.
Yes, and thank you again, Jasmine and Fallon, for your presentation. And I'm really sorry to hear about all the burnout that's happening amongst midwives. I mean, we really do thank you for all the hard work you're doing. And actually, I'm just wondering, do midwives in BC, do they have the ability to provide pregnant people COVID vaccines, or will they? Was there any discussion on that?
So at this point, we have a fee code for it. There is not a. I think you know, Antonella. We're in British Columbia. We're at a phase of the vaccine rollout that is still in phase 1, phase 2. Sorry. So we have everyone who is who accepts the vaccine in long-term health. Like in a position of working in long-term health or in a position of living in long-term health, has been presented with the opportunity to have a vaccine. And I think we have, it's 90-something% for have gone through and gotten one dose, at least one dose. We are now at a point where we are vaccinating people who work in hospitals. So I have my first round of vaccination, alongside the physicians and nurses and unit clerks and administrative staff in the hospital. But we are not at a point where we are actually vaccinating pregnant people. The COVID vaccine doesn't have, if anyone's staying up to date with the SOGC releases on what to do about COVID vaccines, we know that COVID hits people in pregnancy harder than people who are not pregnant, their non-pregnant counterparts. However, the testing for the COVID vaccine did not include people who are breastfeeding or people who are pregnant. At this point, you know, there's no theoretical, like there's a real risk to COVID. And at this point, there is just a theoretical risk to the vaccination in pregnancy. So SOGC is recommending having a conversation, risk-benefit analysis conversation with your care provider for the COVID vaccine. So it's my understanding, if people do feel that they're at a risk of COVID, which really feels like almost anyone in our population, that the COVID vaccine is something to consider. However, we are at a point where it's not being actually rolled out for the general population yet.
Okay, thanks for that. So we have a couple questions. So our first question, you noted that almost all midwives expressed needing more knowledge around immunization, but their clients note that the discussion is of high quality and more transparent. I think this is a clarification question, but there seems to be a disconnect between the two. Oh, sorry.
Hi, I can answer that. Yeah, thank you for that question. I think what you're seeing there is the wide variety in what midwives are doing. So there are some midwives that aren't discussing anything about immunization, and then there are some midwives who are very well informed and routinely talking about it with every client. So the clients who would have said that they considered the discussions high quality would have had midwives that had those kinds of discussions with them.
Great. Awesome. So our next question is, what would be an example of a legitimate vaccine critical document?
Okay, well, I'm assuming this is an open question, not a rhetorical question. I think when I mentioned that we have talked about how to address vaccine critical resources, the idea was more that, first of all, midwives should be aware of what is out there so that when clients have questions about it, they can respond to it in an informed way. And the other piece around that is not necessarily to endorse vaccine critical sources of information, but to reinforce the idea that having questions is okay, and that there are some unknowns, and that when we talk about evidence-based, we're talking about the best available research. And sometimes vaccine critical, when clients talk about vaccine critical sources, they're not talking about it because they're vaccine critical. They're talking about it because they have unanswered questions and concerns, and that is legitimate for them to ask about.
Great. All right, so I have two more questions here. So our next question is, sorry, I believe you mentioned this in the beginning, but are midwives more hesitant about vaccines than other health professionals?
Yeah, so the survey that PHAC did surveyed midwives, and what they heard was that midwifery clients are more vaccine hesitant and midwives are more vaccine hesitant.
Okay. And the final question, thanks for the presentation, being aware that this varies. Could you please provide a little more detail about what the scope of practice looks like across the country for midwives and immunization? And do you know what is being done to promote a broader scope of practice in areas where midwives have a narrow scope?
That's a great question.
Yeah.
It's more than one sentence, but I'll briefly answer, and Fallon, maybe you'll have something to add to it. But the funding model for midwives varies by province. And so I would say that midwives who are working as employees, so for example, Fallon is part of a health authority, Quebec midwives are similar, Manitoba midwives are similar. They have more scope of practice around immunization because they are expected to do what any other perinatal care provider would do. And for midwives that are working in an autonomous model who are basically self-employed, although they're only paying client is the Ministry of Health and Social Services. That scope of practice is something that would have been defined between the College of Midwives and the government and the Association of Midwives a long time ago. So for example, in Ontario, where midwives are self-employed, there's absolutely nothing in their scope of practice around immunization requiring them or allowing them to do it. So what you'll see in Ontario is one midwife or one midwifery practice may take it upon themselves to collaborate with a physician or a hospital to administer vaccines under their orders. But that practice also has to come up with its own protocols, its own vaccine fridge. And I mean, just in terms of labor, but also financial investment. And so you will see across the board, for example, we have midwives in Ontario that aren't discussing Tdap, and then we have midwives in BC who are administering Tdap. In terms of what is being done to promote a broader scope of practice, that's a bit of a thorny issue and complex because of course it goes through regulation, it goes through government. So while colleges and midwives are consistently reviewing and revising and requesting for expanded or more complex scopes of practice, it can be years and years and years for it to go through the system. So you will see in our position statement that we really call on government for legislative, financial, and general support for immunization discussion and prescription and administration to be expanded in midwifery scope of practice. Mm-hmm. I will also note that there are some midwives working in provinces who have experienced such undercompensation and such overwork that they don't want vaccination in scope. And it's not because they don't support vaccination, it's because they can't imagine doing one more thing at the level of time and compensation that they're operating at now. I don't know, maybe Fallon, you want to...
Yeah. So BC actually works the same as Ontario. So we are self-employed. It is in our scope in BC to do some of these vaccines, and like Jasmine was saying, it's hard in terms of like the financial and the organizational just physically getting the vaccine to your clinic can be challenging. And you'll see it different amongst even different practices in the same health authority. We'll have different policies. So the practice that I work at, we work really close to, like, there's a pharmacy right below us. So we actually have a pharmacy order in all of our vaccines. They keep them in their fridge. We send prescriptions downstairs. They send it, like, clients will pick up their vaccine and bring it in and take it right upstairs to us. COVID is changing things a little bit in BC. So pharmacists are allowed to administer vaccinations in British Columbia, specifically the Tdap vaccine, the flu vaccine. I'm not sure about many others. But they would always charge to do it. And now we are actually having our pharmacy colleagues are actually providing, I had a client get, a postpartum client get the varicella vaccine from a pharmacist recently, free of charge. So it's making it so that, yes, we can do it. Yes, we can prescribe it. When pharmacy is available to give it to them, obviously it's a lot easier to pick up your vaccine and get the injection at that site. When pharmacy is not able to do it, or financially that's a barrier, then clients bring their vaccines into us. They pick it up and bring it in on their way in, kind of thing, and we do it at their appointment. We typically do vaccinations at the beginning of an appointment so that most of our appointments are about 30 minutes. So someone's sitting for that amount of time
I'd like to just add, interestingly, Indigenous midwives who are working in more remote, vulnerable communities actually tend to have a wider scope of practice in general. So their course of care may extend beyond the typical 6 to 8 week postpartum period into the first or second year. And they have a broader public health / community role. So you'll see Indigenous midwives doing health education and promotion around infectious diseases, and you'll see them doing screening for TB and vaccinating for Hep A, Hep C. And I know, for example, like Fallon went and worked up north for a while, and she was required to do, you know, an educational module around immunization by that territory. So interestingly, I would say Indigenous midwives are probably working at the fullest scope possible right now.
Yeah, for sure.
All right, so it is 2:01, well, Eastern time. We do have one more question. Would you two be willing to answer it?
Yeah.
All right, so as midwives, do you regularly detail / discuss possible adverse events that could occur as a result of particular vaccination?
Yes. Yes. One of the biggest, why our clients trust us, one of the biggest parts of our job is to provide unbiased, complete, informed choice discussions. And that doesn't mean just one-sided, you know, you should get this vaccine because you don't want rubella and we don't want our populations to end up, you know, having measles run through it. We, yeah, absolutely talk about all sides of it. And I think that goes back to what Jasmine was saying about the, about the question about what's a good, sorry, I don't remember the question. What was a good or a critical vaccine hesitant website? I agree. Like, I think that the people that wrote this position statement, I think that the majority of midwives are interested in having our population vaccinated. However, ignoring the fact that bad things can happen or that there are things printed on the internet, it's not helping anyone. And by ignoring that, we're creating distrust. So addressing it and discussing it can help get rid of that.
Right. Awesome.
Absolutely. And then the only thing I would add to that is if midwives, what we heard from midwives is that if they were not including that in their discussion, it wasn't because they didn't think it was appropriate. It was because they didn't know enough about it.
Right. Well, thank you both for your insights, and also thank you so much for the hard work that midwives are doing. So seeing that there's no more questions and that we also ran out of time, that does bring us to the end of this webinar. So if you do have any questions for Jasmine and Fallon, I believe you can contact Emma. We'll be providing her email credentials in our post-webinar email, so stay tuned for that. But that being said, thank you all for joining us on the webinar today. Thank you again, Jasmine and Fallon, for your wonderful presentation. As a quick reminder, please don't forget to fill out the survey upon closing the webinar window of your device, and we look forward to your feedback. Thank you all. Have a wonderful afternoon and stay safe.